the work of many others in the world. I would like to say hello, special hello to Professor Kero Sikora, who is co-director and one of the main leaders in the world of the Win-Win Initiative and the main leaders on the real global oncology since 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 30 years we was together when we was directing the cancer section in WTO. And we understand that he was not for classic or bureaucratic things. He is scientific man. He is a great clinical oncologist. That's what we need. We need science. I am glad also that we have Pashkim with us. And Pashkim, we will have our next meeting will work in this evening, if you like, or tomorrow, but maximum to make the final touches of our upcoming ninth session next Wednesday at December 20 at 4 to 5 15, with the in combination with the cooperation of University of Titofa, North Macedonia, and the next session will be led by our dear friend Professor Bashkim Zebari from North Macedonia, and we are all with him. And we'll take day 27 off because of Christmas and the New Year, and then we'll restart in 3 January with a hot program, very scientific, not public talks, not general talks, introduction to global oncology as before, but we're speaking about radiotherapy, hypofractionation, brachytherapy, smart bio nanotechnology and smart biomaterials, about solar power radiotherapy, sessions provided by the CEO of Varian and the chief officer of Varian and vice president of Electa, to see the point of view of industries, and from also other research groups and research companies who are partners with us, as Cure Within Reach, as Dr. Elizabeth Charlotte, and other colleagues who are initiating many interesting research and in the world, and we'll hear from them. And they are partners. They are a main partner of this initiative, Win-Win Initiative. We also have in this the upcoming hot sessions a series of about applications where chief editors of big journals will participate, from Lancet Oncology to eCancer to International Journal of Radiology to the Red Journal and many others, and our publisher here, IOP, and many others, and also surely our dear friend and one of the pillars of this initiative, Professor Ricardo Audicio, who is the chief editor of the European Journal of Surgical Oncology. And by the way, beside me now, and he is responsible of it, I speak to him, Mr. Mahmoud Al-Masri, who is the technical coordinator, who promised me since the day that the program of surgical oncology will be available. 15 lectures led by Professor Ricardo Audicio with the European Society of Surgical Oncology will be available and access for all. It is a global oncology university, accessible for all, but we are focused, not speaking general, we are focused on how to increase affordability of better value cancer care. Professor Kero Sikora, would you kindly speak after this lecture, or you prefer to speak now? I don't hear it. Just a moment, just a moment. Hello?
Hello, now you can hear me. No?
Yes.
Yes, you can hear me?
Yes, I hear you.
Excellent.
But
So,
is this not? Yes.
shall I say a few words?
Yes.
I'm
Okay.
sitting in London. It's a great
Okay.
pleasure to be with you, and I look forward to joining in the next few meetings. Um, I spent 2 years in the WHO, and I've traveled to many, many cancer centers around the world, and we all share the same problem. It doesn't matter how rich the country is or how poor the country is. The problems are the same. It's getting the patients in with early cancer rather than late stage cancer. It's trying to get rid of the impression that you all have to be treated as though you were in North America, because that's what the pharma industry want to be, the perception that you have to use very expensive drugs. There is a great curve that I've seen many times, which is the plateau curve of as you put more money in, if you plot money versus gain, therapeutic gain, you reach a plateau. And if you look at very poor countries, they're way below the plateau. They don't have the resources to give the best to cancer patients. You look at very rich countries, especially North America, US, they're way along the plateau at the top. They're just spending far too much money. We know that in the States, 70% cancer costs occur in the last 6 months of life. And that's just illogical to do that in any sort of public health distribution of resources. So the important thing is to get as close to the plateau as you can with the resources available, but not beyond it, because you're gaining nothing. And the trouble is, patients don't understand that, as you know, and Ahmed knows that from his patients, that people want everything. If their mother is ill, their grandmother is ill, she may be 90, but they'll pay anything to get her treated. And I think we as oncologists have an obligation to try and constrain overuse of resources in patients where really there's not much chance of getting any gain. It's a difficult one. It's much easier to say this new breakthrough drug, we'll give you it and see what happens, give you 2 cycles, the drug costs $10,000 each time, and we do that. But I think the best service the group could do, GOIS, could do to the world is make people think about how to translate rational oncology service with the resources available. I mean, when I was in the WHO, I visited the Gambia, and the health minister had this crazy project there where he wanted to open a center for the diagnosis of early breast cancer. Well, the first problem is in Gambia, breast cancer was not a big problem 20 years ago. It's a growing problem, especially amongst younger women, but it wasn't a big problem then. And secondly, the one intervention that's calling out in Gambia was hepatitis immunization to prevent hepatitis B in later life, and obviously hepatoma, which is the commonest cancer on that part of the west coast of Africa. So logical application requires logical structures, and we have to be the advisors to governments about how to do that. So the problem we have is you've got the patient in front of you that wants the best possible care, and then you've got the whole healthcare system that's under stress. And it's not just cancer, it's cardiology with stenting, with heart transplants, it's stroke with all the drugs they can use there. It's a whole range of other disease, renal disease, where dialysis and transplantation is used. We're all in the same boat. It doesn't matter what specialty you're in. We're all constricted by the resources available to us. And even in America, in rich countries, people are doing crazy things like selling houses to get immunotherapy, which has been denied by the insurers and so on. And if you actually look at the advance, I've been in oncology for nearly 50 years now. And if I look at how it was 50 years ago and how it is now, there's an awful lot more drugs, as you know, and an awful lot of fancy technology, IMRT, IGRT, proton therapy, all these sort of things, fully computerized systems, artificial intelligence coming. But what's perhaps missing still is sort of the old physicians, our predecessors from beyond 50 years ago, were much more balanced about outcomes and conveying outcomes to people. So I think the world is not going to go back. Dr. Google is in every country that we practice in. So I'm afraid we're going to have to really try and sort things out in the best possible way. And I think that's why this global initiative is tremendous to bring us together. So I'll stop now and we can listen to the lectures. Ahmed, over to you.
Thank you very much, Carol. And as you stated exactly, our contribution as a great professor like you and all our colleagues as scientists, not to speak about cancer, not to speak about talk about cancer, about public health, but it needs clinical oncology, it needs pharmacology, it needs medical physics, it needs chemistry, it needs even health economics, needs science, not we have enough, I think, speaking. So I would like to invite you again to think about forming panels to discuss the topics that were discussed in session 7 and session 8, because we touches many things quickly about choosing wisely, limitation of choosing wisely. It's very good, but limitation about common sense in oncology, and about its limitation, and about what we can do. That we are open for all. If you can arrange with us and lead these panels for 1 hour recorded, and we discuss also with our colleagues in e-cancer, with Eduardo Gazab and Danny Berg, to be e-cancer video in the same time. If we can arrange this within 1 month or something, will be hot panels, and we are open for all. Also, about the next list that I sent you, about some items, outlines of the sessions of in January, about many approaches proven, is not speaking about just speaking, but many approved, many proved approaches to lower the cost of total cancer care. Some of them lowered them enormously. We need a panel. We invite the big persons from the world with our colleagues, all the co-leaders, and we translate this from speaking into some e-videos and some articles, and to be some guidelines for all will share. We don't claim that we have the full wisdom, but to brainstorming, but we have the same goal. Maybe we have different views, but we have the same goal. If that happens, that will be wonderful.
No, that sounds a really good idea, Ahmed. A really good idea.
With us today, after I finish this lecture, I am anxious to listen to the comments of Professor Christina Stefan, and from Bashkim, from Tawfiq, from all who would like to interfere. Now I'll start to not to be late. Hi, Christina.
Hello, I am Professor Ahmed Zawawi. We start now the third part of this important topic about a general overview for scientific resource saving and better value cancer treatment approaches. This part 3 is based on chapter 14, as I said before, on our books, but with updates and some information, newer information. As I mentioned before, this composed scheme of 3 parts. This today is part 3 of 3. That will its scheme is financial toxicity tumor board, common sense oncology, encouraging probable futuristic approaches, reducing the cost of healthcare entails care redesign, final notes and reflections for wider discussion and further panels. Fifthly, financial toxicity tumor board. As explained in different parts of our books and this course, the physical distress or financial the physical distress or financial toxicity in which patients experience a challenge in paying for treatment are becoming dominant problems for patients with cancer in the USA because of growing care costs and policies of health insurance payers to reduce their levels of spending. That is in the USA. Then you can imagine what in less affluent country and in low middle income countries. So financial toxicity is important and extremely important in lower middle income countries too. It is tragic in some low middle income countries. For that reason, the first financial toxicity tumor board was launched in September 2019 in the Living Cancer Institute. The Living Cancer Institute is composed of more than 40 hospitals and 900 offices that provide more than 12 million encounters per year and see more than 18,000 new cases per year in North Carolina, South Carolina, and Georgia, USA. The Financial Toxicity Tumor Board is modeled on the concept of conventional multidisciplinary tumor board with participation from physicians, nurses, financial counselors, nurse navigators, social workers, and administrators who meets monthly. They are focused on financial toxicity and financial worry and fear experienced by patients and with cancer. It is linked to patient assistance program for an oncological pharmaceutical agent with the domain constitutes critical area of financial toxicity for many patients. You see the needs in USA. So what you can imagine what the needs will be higher in low middle income countries and less affluent countries. As a result of this board, around 60 million of personal expenditure has been evaded for nearly 1,800 patients. It's worthwhile really to mention this. This is very important. In addition to more than 1.3 million copay assistance that was provided for financially challenged patients. In provocative example of management, of financial toxicity through the function of multidisciplinary this board, Ravagan et al. See that this board should substantially ameliorate this growing international problem of financial distress. 6 commonly sense oncology or common sense oncology. Sorry, one moment. I reduce my picture to not occupy the whole picture. Okay. Sorry. Okay. 6 common sense oncology. So it's something new. Common sense oncology. In addition to the respectable objective of choosing wisely, a group of international experts and distinguished oncologists published a proposal that the win-win consider with great appreciation its intention. It's called common sense oncology. States that oncology needs a recalibrated approach that is more patient-centered and prioritize equitable cancer care, an approach that prioritizes patients' needs with treatments that improve survival and quality of life, promote informed decision-making, and ensure that these treatments are accessible for all patients. Richard Sullivan is in an e-cancer video summarized the concept of balancing innovation and common sense oncology. Here is the link to this video. With appreciation to the Nobel Initiative by distinguished experts and colleagues, and understanding the common goal of the all similar good initiatives, we in the win-win movement see every effort should be done not to consider the issue of a challenge or balance between the innovation and access to cancer care of better value. Again, to explain, this is sometimes we say this is something like versus innovation versus good of the people, innovation versus access to cancer care. We say that we should not concentrate on this point, but to concentrate on how science not be challenging, but science should be a way for a most appropriate way for solution. This by implementing science. So it is this situation of innovation, making balance between or challenge between innovation and access to cancer care and something. No, we should be. We have our approach to in science itself. We use science, implementing science, innovation, more innovation. This is really challenging to explore and explore and explore, but focus on the issue of increased affordability of better value cancer care. We see that there is a need of big and wide movement of innovation and implementing science, not against innovation, of more focused on increased access of better value patients center cancer care for the people good. All will win in the real world. Yes, nobody says that there is innovation is a problem. Is a problem? Is a bad thing or no? Nobody said this in any initiative. But this is a challenge between or balancing between innovation and access to cancer care. We see that innovation could be more focused on how to increase cancer care, and in a way that all will win. There are ample places for all initiative, for all colleagues in the world to do a lot, really. Seventh, encouraging probable futuristic approaches. An example is genomic adjusted radiation dose. Scott and colleague published recently in August 2021 a proposal to integrate genomics into radiation dosing decisions. Hence, GOIS-based framework could be the new model for personalizing radiotherapy prescription dose in clinical practice. Till present, radiotherapy drops behind the vast progress done in target agents in systemic cancer therapy. Drops behind, but there are many things are developing now. And this is the future. In our view, we see that in spite that tests could be expensive and that they surely need advanced technology. However, with well-planned interinstitutional and industry cooperation, the test could be more developed and used widely in the West. With more organized and focused North-South cooperation, these tests could be applied in the South. We pose the question for future scientific studies in general, not only for this. As value could be defined as input to relation to output, then could GARD, as an example, or others, could, as this GARD is genomic adjusted radiation dose, lead to better result of radiotherapy and also avoid unnecessary radiotherapy, hence better value cancer care? This needs studies really. It's very exciting to study it. It's reducing the cost of health care entails care redesign. A published article in 2021, August 2021, denotes that reducing the cost of health care entails care redesign. New England Journal of Medicine Catalyst Insight Council members discuss initiatives for decreasing health care costs, such as healthcare transition and home-based care model. This is the reference. A survey on New England Journal of Medicine Catalyst Insight Council shows a desire for greater price transparency, but slow progress on understanding the cost of care. the care redesign offer opportunity, but fee for service payment remained a problem. This is fee for service. The top activities with greatest potential for containing the total cost of care to healthcare delivery organization are: 1. Care redesign. 2. Studies of data that shows cost of care to healthcare delivery organization. 3. Shifting of ambulatory outpatient setting. Shifting to ambulatory outpatient setting. You will see this in the next series of lectures. Studies and data to show code for care to patients. 5. More efficient use of clinical work. 6. Digital technology like artificial intelligence and data analytics. 7. Novel payer contracts. 8. Clinical documentation improvement initiatives. Yes, here is some title, very beneficial, but in the next series of lecture, you will have defined published examples of what to do with this drug, what to do with this radiotherapy, what to do with this intervention. This is based on published data. This will be easier than items, which is very important. These items was very important, but still a little bit theoretical. Theoretical for many countries in the world, in fact, despite they are very, very important. All above recommendations and suggestions are important, but we see that according to the win-win scientific notion, without focused scientific study and exploration, that's what I said that we will see together in the next series, a lot of series between chapter 14 and correspond to chapter 14 to chapter 24 and after, and 23 and after, and clinical research in the world. Most of recommendation would remain plans or wishes in conferences and publications. So we need different examples of what to do in clinics, what to do in hospital. This is what we will show in the main bulk of this modules. For example, shifting to ambulatory outpatient setting without compromising the outcome of patients needs scientific evidence-based study and innovative ideas. Moreover, I emphasize that data on cost, information to care provider, and discussion with patients would not be ethical and inhuman. It's not human at all. Without enormous and focused scientific movement on the goal of the increase of affordability of cancer care with dignity for increasing number of billions of underserved patients in the real world. What the meaning? That it is unhuman to discuss with patients. You are not, you can't afford, you can't, without proposing alternatives. That is a win-win. It implies searching together. It needs a world movement. We don't claim that we have the solutions, but the solution is by many, by you, all of you. The needs are, as we call for, into contribution of most, if not all, scientific bodies, institution, organization, to search for alternative of cost-effective and triple value-based treatment tailored to patients in communities and conditions. Triple value, as prescribed by Sir Moore Gray, personal value, technical value, and allocative value. Many both scientific and pragmatic examples are known in the next lecture in chapter 14 to 23 and in chapter 35 in approaching global oncology. And also there is a lecture about better value and triple value according to what Professor Sir Moore Gray prescribed. Ninth, final note and reflections. In the win-win movement, we emphasize the great need for tackling the problem of skyrocketing rise cost of cancer care and the serious increasing shortage of access and affordability of cancer care to increasing millions of cancer numbers, increasing millions of patients worldwide. It is time to move forward, to using wisely but keeping or better to increase the value of cancer care through clinical research, not just why wisdom come after, not before. After research, after evidence-based, that's what we call for. It is essential to consider realities and to pass the phase of recommendation and dream. There are many recommendations, many dreams, many slogans. Then win-win scenario, smart, and in the win-win scenario, smart ideas, and every effort should be paid to consider the interest of different stakeholders. Hence, all would win in the real world. Otherwise, it will be just aborted dream. But even if it is scientific, but it should be win-win scenario. All will win. And it's possible by smart deals and by smart ideas and smart scientific thinking. Moreover, the win-win scientific international raised warning that most, if not all, economic system will not cope well or will not cope at all with the skyrocketing rise of total cost of cancer care. This is warning. It's evident. Hence, there are risks of upcoming collapse or increasing failure to cope. The goal of the win-win is that all stakeholders, including scientific progress, industries, economies, government, and before all, patients everywhere will win in the real world via smart approaches with implementing science. As the win-win initiative is a notion rather a competing body, we are not a competing body, but a forum for all, but an open forum for all. And we call for all. We are not challenging, we are not replacing any. No, it is a notion. It is a forum for all. Hence, it appreciates all different initiatives, provided that they come together or to collaborate with win-win scientific notions. This notion is not one more, is not no rival result, any, not challenging any. It is forum, win-win notions. Flexible, realistic approaches that consider the real world condition and the indispensable need for progress of science. Is not progress of science is not challenging. It is not a problem, but it could be a solution. I raise our brainstorming points and view for wide feedback and to be included in upcoming panels. We are very open for all constructive comment and feedback from all. In our view, choosing wisely financial toxicity, common sense oncology, or recommendation committees publication aimed at prioritization of treatment or stratification, resource stratification based on who will receive treatment or parts of treatment where treatment can be afforded or not. All are surely very noble initiatives, but in the other hand, they in some circumstances they could be considered as acceptance of situation that should be changed for the better of patients. How we can accept you cannot afford this treatment? No, this is not priority, or this is not priority. Isn't more scientific and logic to focus first on scientific efforts on detecting a lot of already published alternatives of treatment without compromising the outcome on patient, and to increase enormously world scientific effort for innovative approaches, smart models, and win-win deals that result in more affordability of better value cancer care and simultaneously flourish economies and industries. Therefore, we in the win-win movement and the GOIS program and our books are considering with appreciation, choosing wisely, common sense, oncology, financial toxicity board, and all similar needed endeavor, and calling into enhancing all proposal and constructive endeavors by collaboration, cooperation, coordination, and broader scope, evidence-based and pragmatic that consider wide feasibility in the real world. Otherwise, the affordability of cancer care in the world, including rich countries and healthy economies, will have increasing crises now and in the future. Could we come together to the conclusion that the goal of increase affordability of better value could be achieved by a scientific approach that considers the triple value cancer care? Could we come to this conclusion? What do you think? This is a question to all of you, and this you are think you discuss together. All stakeholders and all parties will win. please allow me to share with you some relevant personal reflections at the end. There are published suggestions that whole burden of discussion, the whole burden of discussion with patients about cost of treatment should be upon the treating cancer doctors. Should discuss. It's not so easy. As a clinician and researchers, I see that it's very hard and even cruel to discuss as a doctor with patients that the cost of the suggested cancer care is high than he or she can afford. Which would follow wisely or follow the sense in that case? Will follow the sense here? No, after finding alternatives. How we can face a father or a mother or wife or husband telling that cancer care of their beloved person is not affordable to them, or to choose their other less costly care without scientific evidence that is not less patient-centered outcome and value. Is it better that we as cancer caregivers and scientific and medical communities do first an effort in finding as much as we can scientifically acceptable and published alternatives without compromising the outcome of patients? Then we call our wisdom, our sense, and logic, and not before. How some scientific work or presentation under wrong title to understand the expression global oncology to prioritize delivering radiotherapy to the indicated cancer patient in countries who have no adequate facilities according to the rate or expected survival of cancer. I'm not speaking theoretically or not just a hypothesis. I saw this. And it is not sense to and I discuss this. It's nonsense. How could you recommend that the treating radiation oncology not to deliver palliative radiotherapy as soon as possible to cancer patients with severe pain, for example, bone metastasis, impending fracture, or impending spinal cord compression, or mediastinal compression? I saw this in some trial of publication and in some even conference, and I discussed it. Really, I don't accept it. I see this even in some countries. No. Why? No. Because while there are many scientific approach at present, now is now, to double or even triple the number of treated patients by the existing radiotherapy facilities in most countries who haven't adequate number of service. Yes, it is possible. Look here, the reference here, and this is, I'm not speaking theoretically. I saw this insight in many countries. With adaptable but scientific models in the real world. This is longer term, but now you can double or triple the number of existing patients by the existing radiotherapy facility, and not trying to prioritize this is curable, not curable, not to treat resources. This is stratified, prioritize a patient who will receive treatment. This is come after we do our effort. When if there is no other mean, okay, this is we can do more, but we have to do our efforts first, and it is possible, and it is published how to do many examples, and how we can think together, and we can think even in your countries or everywhere to invent and to explore how to do more. There are many scientific published examples by many authors and institutes in the upcoming lecture of Module 3 in this course, and mostly based on our books. That is about what were published and not used. All these things are published and not used, surprisingly. But unlimited numbers of scientific exploration and research focus on increasing affordability of cancer care in the world are needed. There are a limited approach. Go on. Once again, we emphasize in this group of lectures, in this module, we raise stimulating brainstorming issue. We don't claim that we have the completely perfect statement or the full wisdom or complete truth. Science is perpetual searching forever. So live recording panels will be organized as a part of the program. We are open for all views, all feedback, comments, suggestions are welcome. We are looking forward to receive your feedback. Once again, stress the win-win international scientific initiative and the global oncology implementing science belongs to all and a forum for all. We don't claim any praise, but the credit for the doers, particularly the locals everywhere. We don't claim any request of glory or personal glory or praise on it. The glory is and the credit for the doers everywhere in the world. If you like a copy, as I repeat again, send to us and you receive PDF copy. Thank you for your attention. The success and of all this depend on you and collaboration and cooperation together in the world. And I'm looking forward to hearing from you all. Thank you all and bye-bye.
Now, we have a time, 20 minutes for hearing from you. If we can, Professor Christina Stefan, then Professor Baskim Zebri, then I would like to hear from Professor Tawfiq and Will. And all who would like to add something, please say. Chat now or send to us email. This initiative is yours. Now the floor is for our co-leaders, Professor Christina Stefan.
Thank you so much again, Ahmed. Again, a very rewarding lecture, you and your colleague. Really inspiring and really convincing why the win-win global oncology initiative, and of course, you know, about increasing affordability. I would like to challenge, I suppose, most likely younger colleagues and ask them a question. And I think it will be great if they could answer perhaps in a chat. I think it's great to have a more interactive type of session. I know they are very, they are listening very carefully, but sometimes you still need a feedback from them just to make sure that, you know, we are all aligned. And I would say, what is their approach about a global fund against cancer? Are they for such a global fund or are they against? And again, it's not really a test. Either answers are correct. So there will be some people that they will say, look, a global fund will be good. And there are several reasons. And some of the colleagues might say, no, maybe a global fund will not solve the problem. So maybe each and every one of you, I'm talking about the young colleagues who are online, could add on the chat. So at the end, we could really see how do they think. And again, I said it's not to be judged. It's not the wrong or right answer. It's just a different perspective. So coming now about, we talked a lot, or you talked a lot about being affordable and how can we improve the access to cancer care. And I think at one stage, we mentioned innovation. So another question or something perhaps for you to reflect would be, where does innovation and how does innovation play a role in us? And when I say us, I'm referring at really African countries, helping us to reduce the gap which exists between the more developed countries and ourselves. And another question that I was reflecting while, you know, listening to you was the work at WHO that the colleague prior to Professor Ahmed was mentioning. We did relatively recently, about a year or two ago, a survey looking at a number of African countries to see how are they ready to prepare to eliminate cervical cancer as a public health problem. And we did see that some of the countries, some of the African countries are better prepared than the others. So something that perhaps we could reflect, why some countries succeed better than the others. And I will give an example, and I mean, it's just one example, Rwanda, where I had the chance to live for a number of years, which again is a poor, I mean, not a poor, low-income country, but really which managed to put all the resources in terms of health systems, in terms of political will, in terms of really conviction that, you know, investing in this case, prevention, but not only prevention, because WHO cervical cancer elimination has the 3 components, so prevention, the screening, and obviously the treatment, because we are talking about that, you know, will make a difference at the end of the day. And, you know, if we look now at the last papers, it was expected that Australia to be the first country in the world to eliminate cervical cancer, but it seems that it's going to be relatively a tight competition between Australia and Rwanda, and I wish to see more African countries really starting to invest in understanding the global and the cancer burden which exists in Africa, not only in Africa, globally as well, but which affects us, I would say, much more in terms of infrastructure, in terms of health, I mean, human resources, and so on. So, of course, we talk about common sense oncology, we talk about limited revenue, but what would be perhaps the most innovative ways? And let's assume that one of you would be the Minister of Health, or maybe the Minister of Finance, because you'll have more money. What and how would you invest to make sure that the measures that you take are really the most effective, the most efficient, and which will have the most impact for your country and for your population that you are serving? And again, we say, you know, what would be the best outcome while we treat patients with cancer? But I think, you know, at least on the African continent, we still need to understand the disease better. And I am sure that all of us, we encountered problems when we adopted protocols from high-income countries, and we did see that our patients did not respond the same way of how the patients, perhaps of another ethnicity, you know, responded. So I think we are still in the stage where we need to understand more the disease, and we need to really look for our own solutions, tailor our own solutions for the benefit of our patients. And let me stop here, and I'm curious to see if anyone responded and I see some responses here. Not sure if the Global Fund will solve the issues, and in some cases over-treating. The challenge is the scientific approach, guidelines. It's a good cause, if not politically given to the patients. Excellent, excellent. So I really enjoyed the fact that you are coming with ideas. We had this debate, and again, I said there's no wrong or right answer. My opinion, my personal opinion, is that the Global Fund will not solve the problem, because, and I know there were lots of discussions and arguments that, you know, we have the HIV Global Fund, and why can't we have a Cancer Global Fund? But HIV and cancer are just not the type of the same disease. HIV is one disease, while cancer is not one disease. And the cancer, we treat so many types. And I really believe that the Global Fund will not be the miracle or the solution. Of course, I mean, any financial input helps, but I think we still need to look at ways in which, again, I would say prevention, especially in Africa, where 30% or 40% of cancers are preventable, invest in prevention, and then obviously in the type of treatment, but the treatments which are affordable, of course, but even if they are affordable, we need to make sure that these are the right protocols and the right treatment for our own patients. I will stop here. Thank you once again, Ahmed, for allowing me to exchange few ideas with the younger colleagues. I love interaction, and I hope at one stage we will see their faces as well. And perhaps, you know, we'll give them some homework, some thoughts and some questions that they can think at home about, different angles, different ways in which they can approach, and perhaps, for the next sessions, they could come and let us, know their opinion, because this is the young generation that, that will carry on oncology in Africa in the next years. Thank you so much once again, and to the younger colleagues for listening and for responding.
Thank you very much, Christina. I have just a rapid comment. They are not so young. They represent the most of the present and the whole future. And the whole future, we count on them, and you count on their thinking. Second thing, I don't imagine how I am glad that of the maturity of people that understand that the global fund is not the magic solutions. We have to do our effort first, because there are frankly many corruption in the world. We have to do our scientific work first to lessen the burden of financial toxicity, to propose scientifically many alternatives that could cover. Thank you very much, Christina. And a final point, that please think about, we would not need a panels for 1 hour or 1 hour and 50 minutes recorded, where we invite some distinguished persons, and will be also brainstorming with many colleagues. All can send the question about posing question. Don't worry, in the upcoming 3 months there are many scientific work, because I avoided to make many assessment about something general about views. What is coming is scientific thing about this pharmacology, about this treatment, about this thing, and we need their search. Not just to reply, but search in Google, in books or something, and maybe they give more ideas. Thank you very much, Christina. Now I would like to hear from Professor Bashkim.
Yeah.
And you speak and you tell us about our next meeting next Wednesday.
Yeah, thank you very much, Ahmed. It was indeed a very interesting and informative talk that you gave, and also the inputs from Christina. And concerning the discussion that we are having now, in fact, of course, we have a common burden, and that is the cancer treatment and better, more qualitative cancer care. But also we have to take into account the local differences and local specifics for each country. But all we have one in common, in that the scientific research is a global one, and the results are acceptable all over the world. And it's important that we use these scientific results to convince decision makers to do more in their own countries. I think every country has the possibility to do more in terms of qualitative treatment in cancer care. For example, only one example in our region, in our country, for example, we have HPV vaccine. You know that 50% of girls, they don't take the HPV vaccine because they think, although it's available for all girls to take it, they don't take it because the prejudgment that the vaccine is against fertility. And I think the scientific results here can help in order to convince the people here that the vaccine has nothing to do about against fertility, but it's more prevention against later cancer care, cancer appearance, or cervical cancer appearance. This is one case. So we have a lot of cases here where we can use our scientific research to convince the decision makers, and also to convince the majority of people in our countries to believe more to scientific results, and to take care about this early detection of the cancer care. And next week, we will speak about our experiences, where we are as Southeast Europe, as a Southeast European countries, especially Balkan countries, Macedonia, North Macedonia, Albania, Kosovo, and countries that are surrounding us, we are pretty close to the low and middle income countries concerning the problems that we have, difficulties that we encounter in terms of cancer care, and also some initiatives that we are working to use these scientific results in order that we have a better cancer care. So this is what we are going to speak, but I will let the rest do it for the next week, and we will have also some invited speakers from the region that can will be part of the let's say course in the next week. Thank you.
Thank you, my brother, Professor Baskim Zebri. We'll work this evening to finalize and to send for all. And also, the Zoom link and everything is ready. I sent it to you for the 9th session. I would, Dr. Amal, I would like to hear from you 2 minutes to introduce yourself. Dr. Amal is Associate Professor of Clinical Pharmacy in Port Said, and we need you a lot in the upcoming lectures, because there are a lot of pharmacology, medical physics, many things based that to how to use these sciences to improve cancer care. Just introduce yourself and your affiliation. Dr. Amal, you are with us. Dr. Amal? Okay, I would like to hear after from Professor Tawfiq. Professor Tawfiq also is one of the important authors in our book, and he present a nice lecture really in the upcoming, in the part of radiotherapy after just the part of systemic cancer
I'm
therapy.
here, Dr. Ahmed. Can you
Yes,
can you
Dr.
hear me?
Yes, I hear you now. Yes.
Thank you for all for this lecture. I am Dr. Amal. I am a clinical pharmacist, assistant professor of clinical pharmacy, Mansoura University. I am working now in the Faculty of Pharmacy, Mansoura University, and also in UHIA in Port Said, in approval of chemotherapy for cancer patients. This is a small CV about me. If you wanted to ask me anything about anything, I am here.
We need your contribution in the upcoming lectures, because we need your intervention and all, because there are many clinical pharmacies, there are many pharmacological study related to systemic therapy. I sent the highlights of the upcoming lectures, and I can send it to again. It is based on chapters 14 to 23 and chapter 35 also, but it is updated, and this is coming in the upcoming lecture. So we need your contribution, an active contribution. We are all together to enhance this initiative. Professor Tawfiq, if you are here.
Yeah, thank you very much, Prof. Good evening, good morning, good night to colleagues around the world. Actually, I'm currently in Arusha, Tanzania for a meeting, and the network is not pretty good. That's why you can see me, I'm using both my phone and my laptop, to really try to engage in this very stimulating session. Again, we can't thank you enough, Professor Ahmed, for this great work you are doing, because it's really an uncommon engagement, for people of your generation, to really make sure that most of this hard work that has been done over these several decades, are being passed down the line, And I'm really encouraged, again, just like I mentioned about 2-3 weeks ago, at least my younger colleagues who are just coming up, at least in the last 4 sessions now, I'm really very happy to really see them, because most of their colleagues must have been watching TV and probably going to play football and all that now. But I see they are still online here, so which shows that it's a promising future, for us in the field. I can't agree enough with the contribution of Professor Ziberi and Professor Stefan. I mean, these stimulating discussions, needs to be brought to the fore, so that we discuss all these issues, not just, the science of it alone, but the practicality of bringing about some of these challenges in the real world, and particularly in the LMICs, where we have. I'm really a little bit, should I say, encouraged again with this last comment of Professor Ziberi, that the Southeastern European colleagues aren't too far away from the LMICs. And believe me, I can't wait for your engagements, next Wednesday. Of course, I will have been home, and I will try to do all my best to really improve on this internet service, so that we get the best, out of all this talk that is being put together. And I just want to seize the opportunity again, that we should not be discouraged, particularly colleagues from the LMICs, because the challenges are really very huge, and by the time we talking, about the issues of particularly radiotherapy, because that's where the medical physicists, come in greatly. Although there have been quite a number of improvements in the last few years, but we are still not where we are supposed to be. But be that as it may, for example, this meeting I came in for here is still on safety issues that has to do with all this cancer space and all that, But we just need to be at least patting each other on the back, hoping that the situation can really improve in the years ahead. And with the conglomeration of these younger colleagues that are joining the train, it shows that the future will be better for the treatment of this and bringing about affordable and proper cancer care in the region. Once again, thank you, Dr. Ahmed, for this great work. And we pray that we do this in very good health. Thank you, everybody on the call, and good evening again. Thank you.
Thank you, Professor Tawfiq, but the thanks not for me. It is for all of you, because it is not mine, it is not yours, it is ours, and will succeed only if many contribute and build and modify and crystallize this to and improve it. So I agree completely with you that our consider our younger generation, who are, as I say always, most of the present and the whole future will not be with them in the future. So please be involved, as active as much as you can, because this is your present and future. Now it is I would like to finish with Professor Wilfred Negwa, who run the show. Will, you are here? Wilfred Negwa. Will, you are here? Lensa? Oh, Fatumata. Fatumata, she is a coordinator for this nice work, and thanks to her for her work with Mr. Mahmoud Masri and Dr. Fatumata and Lensa. Lensa, hi to everyone. If any of you, please, if you would like to add any points, welcome. Not only now, but send, and it will be forward to all our colleagues, to distinguished experts. This will grow with this. Now is the time to finalize this session, and I'm really very glad because I am among you. This is your endeavor, and going forward, hand in hand, and for fruitful cooperation always. Thank you all. Thank you. It is yours. It is yours. Thank you all. Bye-bye.